know if, let me stop share first.
All right, can you see this?
I can. Can everybody else see that? I think everyone can. If you can't, enter it in the chat box.
Perfect. All right, if anyone can't hear me, feel free to speak up. It's a fairly informal presentation, and I definitely encourage questions at any time. So Brianna will pipe in and go ahead and ask them. Also, just a heads up, I do have some pictures of colic surgery. So if you're queasy or worried about any of those images, they are in here. And I'll try to kind of give you a little bit of a warning. So I work for Referral Equine Hospital in Saratoga Springs. I'm a veterinarian, and then on top of that, I'm a boarded surgeon. So I did 2 internships and then a surgery residency after vet school. And I've been practicing for a few years now. I do both soft tissue and orthopedic surgery, and I work on all types of horses. So today we are going to talk about, no, my PowerPoint's not working, predictably. Sorry guys. Oh, here we go. Today we're going to talk about colic, and I'll start off by kind of defining it because that seems to be something that is open to a lot of interpretation. So horse owners and a lot of people tend to think that colic just means gastrointestinal, so twisted colon or something wrong with their small colon. But really, colic in horses is just a word for abdominal pain. So that can be from their gastrointestinal tract. That can be from their urogenital tract. We have horses come in that have bladder stones or an ovarian tumor or a twisted testicle intra-abdominally that are causing colic signs. And then we also see a wide range of other things that can cause things that look like colic. For example, I did work in Florida for a bit. We had a lot of stinging nettle there, and a horse that rolls in a lot of stinging nettle in a pasture is almost indistinguishable from a violent colic. You can't keep them standing. They're incredibly painful, those sorts of things. And so that's just one thing to keep in mind when you call a veterinarian up and say that your horse is colicking. To us, that can mean that they have a wide range of actual problems. It doesn't necessarily just mean their gastrointestinal tract. I like to kind of go through with horse owners as far as like what you can do when your horse is colicking on farm. My number 1 rule is just to stay safe. So if you're I was raised in 4-H, and we were always told to walk our horses around. You know, if they're colicking, walk them around. You don't want them to roll. The actual truth is that if they're colicking, then rolling's not going to hurt them more. So if they're colicking, they're painful because something is already twisted or out of place. Rolling is not going to make them worse. So if you find yourself putting yourself in harm's way to try to keep your horse standing or to keep them walking if they're really painful, definitely don't do that. So if they're violently painful and they can't stand up or something like that, then just keep yourself safe. That's really important to me that owners stay safe. One good thing is to know your horse's normal vitals so that if they're colicking, when you call your veterinarian up, you can say, oh, his heart rate's elevated. So normal heart rate for a horse is, and don't quote me on anything, this is just our normals that we go by in hospital. Normal heart rate for a horse is 20 to 48 beats per minute. That can be very dependent on the horse. Normal temp, 99 to 100.8 degrees Fahrenheit. Respiratory rate, 10 to 20 breaths per minute. So if you know what your horse's normals are, then you can say, like, when you call your veterinarian up, you can say, hey, he's pawing a little bit, he laid down twice, and his heart rate's 60, and you know that that's abnormal. So those can be really helpful things. The other thing which a lot of our owners are really good at is tracking fecal output. So if you know every morning when you clean your horse's stall, he normally has 5 piles, and this morning there was only 1, that's a little unusual. That can mean a couple things. That can mean he hasn't been eating as much, but it can also mean that he hasn't, his GI tract has slowed down somewhere along the way. If your horse, stays painful or uncomfortable or still is acting kind of funny, I definitely recommend calling your veterinarian. And this is where it really helps to have a relationship set up with a veterinarian that, that you know and trust, or veterinary practice, and someone that does your vaccinations and a lot of your preventative medicine, and then have their phone number available, or whoever is on call for their practice. A lot of equine veterinarians are doing emergency sharing and everything like that. And, you know, basically you're going to get someone that's well trained to evaluate a colicky horse. They may say, give him some Banamine, see how, you know, some oral Banamine, see how he does. You know, we kind of hear that a lot, and that's fine, because honestly, you know, I'm going to go over what happens to a colic in a referral center today, but I'd say 80 to 90% of colics I never see. So most colics are taken care of at home, either by you guys by just monitoring, or by an ambulatory veterinarian that is able to come out and relieve their pain, and do some diagnostics on farm. So again, just to emphasize, the big main thing that I like to tell people is just stay safe. That the idea that your horse must be kept up and walking to prevent it from the colic from worsening, you know, not a thing. Don't get yourself hurt, you know, trying to keep them up and walking. Sorry about that a little. You call your ambulatory veterinarian out. Some of the things that you're going to see them do will be to repeat the vital signs that you took. And again, this is just because things can change within the course of like 10 minutes. Like we see that in our hospitalized cases, but you know, we really closely monitor all their vital signs, and we see them change in the course of 5 to 10 minutes. They're going to listen for gastrointestinal sounds using a stethoscope, and then they'll perform some basic diagnostics. So for most ambulatory veterinarians, that means rectal palpation and nasogastric intubation. What we're feeling for a rectal palpation is any gas distension of their abdominal structure. So their large colon, if it's twisted, then we can feel that usually via rectal palpation. If they have a piece of their small intestine twisted, we can feel that in rectal palpation. We can feel impactions of the large colon. So it's really a pretty good diagnostic for us. The one thing that I always tell owners is that our arms are only so long, and you can see how large your horse's abdomen is. So when we do a colic exam, either in the field or in hospital, what we're really doing is trying to piece together a bunch of puzzle pieces, each of which only gives us a little peek into why your horse might be hurting. So if your vet doesn't have anything conclusive on the rectal palpation, it doesn't mean that your horse is fine, and it doesn't mean that your vet's bad. It just means that maybe there's something hiding further in there. The other both diagnostic and treatment that we do is nasogastric intubation. And that's where you'll see us kind of shove that hose up your horse's nostril and into their stomach. You sometimes will have to twitch horses for that, or administer some sedation, because obviously it's not something that they enjoy having done. And the reason for that is because horses have really strong esophageal sphincters, so they can't regurgitate if their stomach is full. So that can be kind of a lifesaver from an ambulatory veterinarian perspective, because horses' stomachs will rupture if it's too full. And where we see that is if they have their small intestine isn't moving things downstream, and then fluid builds up into their stomach, and then if they can't regurgitate it, then obviously that can cause damage to their stomach.
So we had a question, and it was, what kind of drug is Banamine, and what does it do?
Yeah, so Banamine is a non-steroidal anti-inflammatory drug. And so it basically works a little bit like, you know, like horsey Tylenol. We tend to think of it more for like colic and soft tissue things, as opposed to Bute. It's kind of like Bute's counterpart. So it's a mild pain reliever. Any other questions?
I think we're good for now.
Okay. So, you know, your veterinarian will come out, they'll, you know, probably administer some sedation, administer some Banamine. They might administer some anti-spasmolytic drugs. So some drugs that make it so that, the large colon or the GI tract isn't spasming as much. And then if your horse is doing well when they leave, then they'll be like, oh, give me a call, you know, something's going on, you know, and go on to their, you know, kind of their next emergency. If, however, your horse is continues to be painful in spite of everything they've done. So they're going to give the sedation that we give also has a pain management effect. And then they're going to probably give some Banamine if you haven't already. So if the horse continues to be painful, even though they've given those things, or if they find something on their exam that leads them to believe that the horse needs surgery, then they're going to recommend referral as long as that's a feasible option for you. The other big reason that I encourage referral for some owners is the ability to monitor. So we're staffed 24/7 at this hospital. We take your horse's vital signs at least every hour. Someone is in there. So, and then we have cameras up, we're constantly watching them. So even if your horse doesn't have that severe a colic, I sometimes tell people, let us do the worrying for you. If you're thinking that you're going to be camping up, all night outside the stall, or you're really stressed about it, we can definitely take that, even if they don't need any treatment, we can kind of take over the monitoring for you. If a horse is referred into hospital, then you'll see us repeat, when you come in with your horse, you'll see us repeat a lot of the same things that your ambulatory veterinarian did, and then a lot of the things that you did already. So we'll start by just doing a thorough physical exam. So that's the same thing that we talked about already. We're looking for changes in heart rate, and we're looking for changes from what you told us and then from what your ambulatory vet has told us. I'm going to repeat a rectal examination. And again, I'm not checking to see if they missed anything. I'm checking because things really often change within the course of a trailer ride. We're going to repeat nasogastric intubation. So again, putting that tube up the nostril and into the stomach. And then another additional diagnostic that we do in hospital on every colic, and that some ambulatory veterinarians are starting to do, is abdominal ultrasound. So this kind of gives us an extra peek into what might be going on inside the abdomen. And the image that I have up there on the screen is what small intestine looks like when it is twisted off. So what happens is small intestine gets kind of gassed up or gets something wrapped around it, and then it isn't able to pass things downstream. And so those black circles are just small intestinal loops filled with water. So abdominal ultrasound is a big one for us. It can help us both detect problems, and then based on what problems we think are there, it can help us to try to give you guys a better prognosis for what might be going on to your horse and with your horse, and then make a recommendation for surgery or for medical management. Another thing that you might see us do is take a sample of their abdominal fluid, and that's that bottom word on the screen, abdominocentesis. Basically, the horses normally have some fluid in their abdomen. That's a very normal finding. They all have it, but we can compare some of the values on that of that fluid, compare it to the values in their blood, and that can tell us whether or not they need to go to surgery. That's our goal with our initial examination, is to decide whether we can manage them, quote unquote, medically, or whether they might need surgery.
We have a question. It is, I assume having a baseline of vital signs is helpful prior to an issue. Can you recommend a reference on how to take the vital signs and what equipment is necessary for the owner?
Yeah, I think it's probably smart for every owner to have a stethoscope. You don't necessarily have to have that. A thermometer, which thanks to coronavirus we all have now, and that should be it. I mean, you probably don't necessarily need a stethoscope. You can feel their heart rate by putting your hand on the left side of their chest. Their heart is like right behind their elbow. So you can feel it there, or you can feel it under their jawline. You can feel their pulse from one of their arteries there. Their respiratory rate, I tell people to look at their nostrils. I think, there are a lot of good online references. Cornell, I believe has some probably associated with the university and the cooperative extension. Just get something that's definitely referenced through, I'd say, university or something like that would be, not just somebody's blog. My recommendation would be probably going through a Cornell website. As far as basic things, I'd say a thermometer and a plus minus a stethoscope. You don't need no veterinarian is going to ask you what your horse's GI, gastrointestinal sounds are like, anything like that. The big things would just be normal heart rate, normal respiratory rate. and that. And again, if you haven't done those things or can't do those things, again, we're not upset, but those are just nice things for you to be able to monitor, I think.
And then we have another question. What information does the nasogastric intubation give you?
Yeah. So if we pass that to the horse's nostril, we're looking for what we call reflux, which means normally horses have around 2 liters. Their capacity of their stomach is 9 to 14 liters. Normally they have around 2 liters just of fluid just sitting in there. So what we do is we pump a little bit of fluid in, and then we always tell people kind of like siphon off of someone's gas tank, which I've never done, so it's a very weird reference to do. But if y'all were to, then we try to see how much fluid we can get back out. So some horses, so for example, this horse is that we ultrasounded in this image on the right of the screen there. When we put in like 1 liter of fluid, we got back like 14 liters of fluid out of his stomach. So what that tells us, and it all kind of fits together with this horse's puzzle, is that if he has a lot of fluid built up in his small intestine or built up in his stomach, we know that his stomach isn't able to empty into his small intestine. And so for some reason, his small intestine isn't able to move things effectively downstream. We basically separate that into one of 2 big reasons in horses. One of them is due to inflammation, which is what we call an anterior enteritis. And so in those horses, if we take the reflux off of their stomach, then they get completely comfortable because it's just inflammation. So the only reason their small intestine isn't working is because the walls are inflamed. We don't know why it happens. Our treatments for it are just continuing to empty their stomach and just keeping them comfortable until that inflammation goes away. The other reason that their small intestine wouldn't be moving things downstream is if there's something blocking it. So this can be the fact that it's twisted. This can be, they get these benign fatty tumors in their abdomen that can sort of loop around the small intestine. So our main goal with the nasogastric intubation is that it can tell us if they have a primary small intestinal problem.
That is where we're at with questions for now.
Okay, perfect. So we'll move on, we'll use, in the hospital, like I said, my main goal in that colic exam, and the way that our hospital works and many hospitals work is that we try to do that exam both thoroughly and efficiently, and then we have the capability, if we need to drop that horse in surgery right away. One of the things that we found specifically when we look at large colon volvuluses, which is when a large colon is twisted, which that's the horse's version of their large intestine. One of the big survival factors was how quickly they got to surgery. And so in our hospital, our goal is that from the time that they walk in the door, if they need surgery, and again, only if they need surgery, that we recognize it and that they get on the colic table within 20 minutes. And we usually are able to accomplish that. So again, time's a big factor. So in our initial colic exam, our goal is to determine whether or not your horse needs surgery. And if it does need surgery, get the ball rolling in that direction. If it doesn't need surgery, get rolling on medical management. So medical management in our case is often intravenous fluids. Usually if a horse has been colicking, then they need, then they're dehydrated. So we need to restore that into their bloodstream. And you can kind of see in this image, we have what we call coil sets. So we put an intravenous catheter in your horse, and then we hang 10 liters of fluids at a time, and the extension set is coiled so that if your horse is uncomfortable, or even if they're just kind of tired, when they lay down, the catheter stays in, the fluids stay running, and everybody stays comfortable. And that's our goal. And then this patient here is getting actually acupuncture post-operatively, so it's not completely representative, but intravenous fluids, part of our medical management. Pain management, if they still have mild pain signs and we don't think that that surgery is either indicated or is an option. Gastric decompression, which that was our word for, we'll keep that nasogastric tube in and we can just pull fluid off their stomach if we're just dealing with small intestinal inflammation. And then again, the big I think the big thing about having a horse hospitalized is the amount of monitoring that they're getting. Again, we have 2 technicians here, 24/7 at least. And then at night during the spring, we have a veterinarian here as well. And then I live 2 minutes away. So for us, medical management, we will continue this unless the horse's pain is unresponsive. So if I think that, it's very likely that, that it's just small intestinal inflammation, or that he's just a little gas distended, then of course I don't want to take him to surgery. But if they continue to be painful, even though we're kind of checking all those boxes, then that's often a reason that I recommend taking a horse to surgery. I tell owners, we call the surgery an abdominal explorer for a reason. Like sometimes I don't know exactly what I'm going for. I just know it's the next diagnostic. And then if their clinical signs or their vital signs deteriorate, so if they get more painful, if their heart rate goes up, their respiratory rate goes up, their ultrasound changes, or their rectal exam changes for the worse, then we're going to think about recommending surgery. For us, that's always, it's always a very large conversation. None of these decisions, we kind of all make it as a team with the owners, barn managers, and referring veterinarian. Usually what I tell owners is if we get a colic in at 6 p.m. that no news is good news. Like if you don't hear from me, then nothing changed about your horse. They were nice and comfortable, no surprises, and you'll hear from me in the morning. If your horse gets more painful, then what happens is our whole team will kind of come in and descend on them again. So we'll repeat all of our exams, all of our, the ultrasound, the rectal exam, everything like that, to see if anything has changed, to see if we have any reason to believe that we won't be able to manage them medically.
We have another question. Is a colic table different than a normal table?
OMG, I think I have a picture of a colic table in the next. Here it is. So we have a Shanks surgery table. So this is a horse under general anesthesia. And I put this picture up here to kind of prepare people, because this is often what people find to be the most traumatizing part of watching their horse go to surgery, if they have to go to surgery. We hang them upside down to get them into surgery. You can see on the right, they were anesthetized in a completely padded room. We really heavily sedate them and then give them a drug that's basically the equivalent of URI that count backwards from 10. And then they're like slowly brought to the ground by a group of like 4 to 5 people. And then we attach these hoists, these shackles to their legs, and then we have a 2-ton hoist that is able to lift them up into the air so that we can drop them on this table. And then if you look at the table that the horse is hovering above, that is actually a Tempur-Pedic mattress that we have wrapped in like a bioprotective. So basically the purpose of that is to decrease anesthetic complications. So horses have a lot of muscle mass, and obviously their hindquarters and their back and everything like that isn't made for holding their weight for an hour-long colic surgery or a 2-hour-long colic surgery. So we provide a lot of padding, like a Tempur-Pedic mattress, and then when you'll see them hooked up into surgery later, a lot of padding on their shoulders and everything like that, so that we don't get any muscle problems from the anesthesia. So in that way, a colic table is, we use a colic table for a lot of other of our routine surgeries, our elective surgeries, but a colic table in general is going to have ours are all Tempur-Pedic mattresses for colics. Did I answer your question? Good. So this is a horse, being in dorsal recumbency, being wheeled. And then again, the way our hospital is set up is so that we're able to drop a colic again within 20 minutes, 10 minutes of it walking through the door. Some horses, if they're really painful, they get about 2 minutes. So they just go straight into the induction stall. One of the things that's important to provide for, equine anesthesia is invasive blood pressure monitoring. You can see we run our horses on a ventilator, and then we have veterinarians running the anesthesia for our emergency procedures. So that's a veterinarian right there running it. And then we do invasive blood pressure monitoring. And again, that's one of our goals we have really low rate of anesthesia complications for our practice. And this is because we put a little catheter in every patient's artery so that we can know what their blood pressure is, and we can make sure that their blood pressure stays high for the duration of the surgery, and that really decreases our complications. We oftentimes put multiple catheters in under surgery so that if we need to administer plasma or other agents to help keep their blood pressure up. And yeah, basically this is a veterinarian whose one job is just staying right up there with the horse and monitoring it the entire time. We're breathing for them, as you can see on the front there, and with the ventilator closely monitoring their tidal volume and everything like that to make sure that that they're getting all the oxygen they need. We also take blood gases, usually to start with every half hour, and then more frequently if we have complications. So that's another way to measure their oxygenation in surgery. These are some colic surgery pics. So this is our surgery suite up in Saratoga. You can see obviously lighting's really important, and then the patient is completely draped off. So you kind of wonder how we take like this big colicky animal covered in mud. People are always apologizing about the horses being dirty. It's fine. We completely drape them off. So there are multiple layers. Those are those blue drapes right there. You have your primary surgeon, which is me in this image, and then an intern and sometimes 2 or 3 on the other side so that they can help in case we have to do, you know, resections or something like that. You know, when we talk about, you know, when I talk about how important it is to get a horse in quickly, and when we worry about intestine being devitalized, these are just some images of that on the right. So these are both images of small intestine, and you can see how there are segments of it that are black. And that's because they've had their blood supply cut off. And so our goal is always to try to detect it before it dies, like before it gets black like that, because then we can avoid having to do what we call a resection. And if we can avoid a resection, we want to. It's not the end of the world at all to do a resection. We do plenty of them. Many horses do well, but obviously if we can avoid having to take out a devitalized portion of small intestine, I would like to go that route.
So we have a question.
Mm-hmm.
It says, how different is this procedure from other animals, and how common is colic in horses?
Colic itself is actually fairly uncommon. I think like 3 to 4% of the equine population colics, and again 80 to 90% of those are taken care of on farm. This procedure is very well. I'm a large animal surgeon. I'm an equine surgeon, so it's very different from small animal. We have a lot of different considerations. The anesthesia component is very different for equine surgery. Often we're kind of getting a little more now into equine surgery where it's more boarded surgeons doing it, whereas in small animal it's a lot of veterinarians that haven't done a surgical residency that are doing your abdominal explorers and everything like that. The reason that I think horse surgery is moving more towards boarded surgeons or these larger referral facilities is because of the anesthesia and the tables, you know, like those tables, that Tempur-Pedic mattress, you know, all that stuff that really minimizes your anesthesia complications, that invasive blood pressure monitoring, that requires keeping a lot of staff on hand and a lot of really well-trained staff. You know, the surgeon is one thing, but it really is the ancillary crew that surrounds them, and having, you know, these huge surgery rooms that are really well lit so that we can just deal with whatever, when I open up that abdomen, whatever I find in there, I can deal with right away, you know, very quickly. We know that our surgical time is a big factor in our survival rate, you know, and in our complications. So we don't want to have to search for any instrumentation. We don't want to have to, you know, go find something in another room. Like, we want to make sure that, like, we have the staff that is trained and all the facilities and equipment necessary to deal with any problem we can find, which is a pretty wide variety in an abdomen. So from my perspective, it's very different from, you know, from small animal, because, you know, my dog weighs 40 pounds. So you can lay her on her back and for like 4 to 6 hours and she's not going to hurt her muscles. You know, she's used to laying down, but, you know, we have horses in hospital that are upwards of 1,800. So they can have complications if they're not really carefully monitored, you know, for a longer surgery. Kind of get into some post-operative management stuff now, and you guys can feel free to ask a question at any point. This is one of our recovery stalls. So we do a rope-assisted recovery. So this is a horse, again, on a hoist moving into a recovery stall. those are completely padded, and then the floor is even padded so that their hooves can kind of grip into it a little bit. And then there are 2 attendants that are in there with them with the head and tail rope. And those aren't so much to pull the horses up, those are just to balance them. And then our goal is kind of to hold them down until they are oriented enough to be able to know where their feet are. Because we're basically asking them to go, like, they're prey animals, so they want to stand. And if, you know, you or I had a colic surgery or an abdominal incision of some, I mean, we'd be on bed rest for a fairly extended period of time. They need to be able to stand right away. So our goal is to kind of make sure they have their wits about them as much as they can before they're allowed to get up, and then to help them balance once they get up. And we do that fairly successfully with a combination of head and tail rope assisted recovery, 2 people in the stall, a 3rd person always outside, and then obviously the padded stalls.
So we have 2 questions, which you kind of partly answered. One of them is, how do you minimize the chance of injury when a horse is coming out of anesthesia? I know of several horses who broke a leg and had to be euthanized after successful surgery. The second question is, do you routinely do assisted recoveries with every surgery, including fractures?
Could you repeat the first question? What do we do to minimize fractures?
Hold on. How do you minimize the chance of injury when a horse is coming out of anesthesia? And they said that I know of several horses who broke a leg and had to be euthanized after a successful surgery.
Yeah, absolutely. That's, you know, and one of the things that we deal with in our Lexington and our New York practice especially are that we work in broodmare populations. So lactating broodmare, you know, that's producing milk for her foal is mobilizing a lot of calcium. So we always really worry about those girls in recovery, you know, about their bones. And especially like we're asking, I mean, these are 1,200, 1,500 pound horses that are recovering from anesthesia. We administer calcium intraoperatively to try to mitigate that. And then using the gas anesthetic has been shown to help with recoveries, especially the gas anesthetic that we use. We give them a sedative as we go. We kind of have like a very tightly managed sedative protocol for when they're going into recovery. And that is different for different procedures. And then it's really titrated to each patient. So, so I have very specific preferences on the sedatives I like my horses to get before they go into recovery. And then every single horse, unless they are dangerous, you know, unless they're like a dangerous animal to be near, they get assisted recovery with 2 attendants here. So that's whether it's a fracture or an ankle chip or a mass removal or a colic surgery, you know, or a tooth removal or something like that. Like every single horse gets an assisted recovery. That's one of the big things we do. Unfortunately, there is still, you know, fractures are a recovery complication that happens. Across our practices, we have like a 0.01% complication rate, which is fairly low. But the padded recovery stall, the attendants, our fracture protocol is extra doses of sedation. So that our goal is to kind of, again, make sure that like about the time that they're ready to get up, they kind of know where their feet are and they're able to orient themselves really well in a room. Was that specific enough, or do you have any more questions?
We have one more question, and it's, okay. Can you please address NSAIDs before and after colic surgery for horses with ulcers?
Yeah, certainly. That's a really big one. So ulcers are, you know, it's a huge problem, you know, squamous ulcers, glandular ulcers, we're seeing that a lot more. What I always tell owners is that we know that there's an increased incidence of ulcers after using buterbanamine. We can fix your horse's ulcers. Like we can make sure that they're not super painful from them, you know, that sort of thing. I have had a few owners that really don't want me to use Banamine post-colic surgery. The way that I look at it is if I had my abdomen cut open and then they have to stand and their entire GI tract has to hang on top of that incision, that's got to be painful. And horses are so tough, and we take it for granted, you know, that they're very tough. So I I use Banamine for usually 3 days, twice a day, post-operatively in almost every horse, and then I knock it down to once a day, and that's full dose, and that's IV, because they're in hospital for usually 3 to 5 days post-operatively. And I wouldn't, probably wouldn't recommend not doing that. I know that we're gonna stand an increased chance to, to cause some ulcers from that, but to me, we offset that. Most of our horses are on gastroprotectants, so they're on both sucralfate and GastroGuard while they're in hospital. The sucralfate helps bridge the gap until the omeprazole kicks in. It usually takes about 3 days for those proton pump inhibitors to work their magic. So I think having those horses on those drugs at the same time that we know they're getting NSAIDs will, to me that mitigates the amount of ulcers we get from that. But it is a risk we take. But we can heal your horse's ulcers, but so that post-operative pain, that incisional pain, those sort of things. Sometimes I don't know if that's really fair to them.
We had one comment and it says, we have a horse that cribs. I was told we need to watch him because he's more likely to colic. Is this the same for wind sucking? And do you have any suggestions to stay on top of this other than cribbing collars or straps?
Yeah, no, there is an increased incidence of colic, really specifically a colic called an epiploic foramen entrapment with horses that crib and windsuck. And it's the same thing because when they windsuck and they hook their top teeth over top of something, they increase their abdominal pressure or they decrease it, really quickly. And that's what can sometimes, for some reason, entrap these pieces of small intestine where they shouldn't be. That cribbing collar works really well. So it's unfortunate. I know some horses get those white marks and everything. The other thing is that I've had some owners do is do some environmental management of their favorite spots to crib and see if you can in some way modify those so that they're not so attractive anymore, and you can kind of get creative with that if you don't, if you don't want to use the cribbing collar, if the cribbing collar doesn't work for you. But the environmental management has been really helpful for some owners that I've worked with. But it's a problem, and not to mention that they destroy your barn while you're worried about them colicking. So. Any other questions?
No, I think we're good for now.
Okay. So again, this is our, pretty standard recovery right here. Then some of the other things we do for our post-operative management are a lot of hand walking. So I'm a really big believer in moving around, and we know from studies that they do in humans in ICU that we get a better GI motility when people are moving around, like physically walking, even after major surgery. So we hand walk our horses, even, you can see this horse is muzzled, obviously. And then owners always think it's really mean, but we hang hay nets in the stall all the time, even if a horse is muzzled, because I kind of describe it, if you or I drive by McDonald's, well, maybe you guys are much healthier than I am, but if you drive by McDonald's, you're going to it's going to get like your GI motility going up, salivating, that sort of thing. We see the same thing with hanging hay nets or just giving them the idea that they might have a chance to eat. It's not just because we're meat. And then our goal is always just to get them eating as soon as possible. Sorry, I'm going to tilt this. Get them eating as soon as possible, because horses, their entire GI tract is set up to kind of constantly be eating and grazing all the time. And some of our patients, like this video play for you guys, but sometimes their babies will cheat on them and steal food. But these are just some of the post-operative management things that we do. Intravenous fluids, obviously, antimicrobials, and NSAIDs, are all the basic coverage for those. Anybody have any more questions?
I don't, there's none in the chat box as of right now.
I have a question.
Anyone can, oh, go ahead.
So as far as the assisted recovery, I just want to make sure I understand. So when they're coming out of anesthesia, there's 2 people in the recovery room and you give them sedation. So that would be like if you sedated in my barn and then it would wear off gently and they would already be standing. So this would help them to stand they have a little bit more wherewithal about where they are. Is that correct?
Yeah.
Or okay.
Yep. Yeah. So yeah, our goal is to kind of titrate, because I mean, if they were to, I mean, they're a pre-animal, right? And they're so good, but we take for granted how good they are about everything we do to them. So they're gonna wake up, are in a blue room, a padded blue room with two people that they don't know, there may be some degree of pain. So everything in their body is gonna be like, I need to get up and get out of here, now. And that's why horses have rough recoveries, is because everything in their body is like, this is a dangerous situation. Even if we have the lights low, we do everything we can to mitigate it, but their entire everything that they've stood for their entire lives is getting away from danger like this. So we find that using different sedation protocols depending on both the horse or the surgery, or specifically, can help us sort of ease that transition without, our goal is not to make it so that they're woozy when they're getting up, but our goal is just a little bit of an anxiolytic, like I'm okay, I'm just gonna kind of then our big goal, like the best recovery, our favorite recovery, is if they just kind of roll into sternal and kind of like look around, and then slowly get up. That's our goal for every case. That can't happen every case, because everyone's different, but our goal with our sedation management and with our entire anesthesia management, we're constantly talking to the anesthetist in surgery, making sure their blood pressure is up, making sure that we have a healthier animal that is going into the recovery stall than the one that we dropped. You know what I mean?
Yes. So has there been anything done about recovery and water in like a sling or anything like that? Has there been any tests or any ideas to mitigate the same thing? So they would already be in a standing position in a sling, and then as they come out of it, you could lower them so that they feel the bottom of the pool. I'm just asking silly questions now.
No, it's not a silly question at all. There are a lot of pool recovery systems and a fair amount of facilities that have them. Yeah, so exactly not a crazy question at all. So there aren't any large scale studies done on the amount of complications that we see with pool recoveries versus not pool recoveries, and that's just because of something we battle in equine medicine all the time, is just numbers. We don't have like hundreds of thousands of anything, so but there are some recovery systems. We do elect to use slings in recovery on some horses if it's one that I'm sometimes we have to do surgery on neurologic horses, and so if it's something that I don't think is going to stand, then we might use a sling to begin with to kind of them with their weight bearing, and then the pool recovery systems are used for fracture repairs at some facilities. They have their own complications because you're picking a horse up in water, which they're not used to. But that's not a crazy question at all. That's a plan that a lot of people utilize.
Thank you very much.
No problem.
So we have
a couple more questions in the chat. Anybody can speak up as well, but in between I'll just read the chat ones. Let me make sure. Okay, what is the recovery percentage versus relapse?
Yeah, so that depends on what we find in their abdomen. So probably one of the more common types of surgery that we do in a general horse population would be a strangulating lipoma. So that's your older horse that colics and needs like a small intestinal resection. And so when I say resection, those are those pieces of kind of devitalized black small intestine that we talked about. So I have to take those out, and then I have to kind of reconnect the plumbing of the healthy small intestine. So the numbers that we have on those types of horses are usually at 80 to 90% of them do well post-operatively. The unfortunate thing about the way horses are designed is that just because I fixed one problem that your horse had in its abdomen doesn't mean that it can't get all the other problems. So just because someone did a small intestinal resection 5 years ago and he did great post-operatively doesn't mean that he can't get a large colon twist or an impaction or gastric ulcers or all these sorts of things. So I always try to tell owners that, you know, it's not like taking out an ankle chip, and people generally understand that really well, because we know that for ourselves too. You know, just because I fixed one problem, you know, in my body doesn't mean that I can't have other ones. I think the big thing as far as like demystifying colic a little bit is realizing that it's just a term for abdominal pain. So it can be for anything. Gastric ulcers can cause colic, you know, both medical, surgical, you know, all those sorts of things. So we generally say that if they make it out of hospital with most colic surgeries, so, you know, short-term survival, that you're going to do pretty well. One thing that we do see is adhesions, which is really common in people. So a lot of people know about that as well. But from whatever caused their colic episode, they can have a lot of inflammation in their abdomen. And basically, when they have all that inflammation, the lining of their small intestine or their large colon or whatever gets irritated, and then it gets really sticky. So post-operatively, it can stick to each other, and that can be uncomfortable when they're eating or that sort of thing. That can cause some colic signs. As far as that goes, usually we tell owners, you know, with adhesion pain or that sort of thing, what they have at 6 to 8 months is what is, if they can make it 6 to 8 months without their horse having signs of adhesions or any colic signs or anything like that, then they're gonna do well. You know, one of the questions we get all the time, frankly, is about older horses. And so as a profession, we've done quite a few studies on looking at colic surgery in older horses. And we find that statistically speaking, the only difference is that they have a longer hospital stay. So I think on an average, like 1 to 2 days longer, and that might be off a little bit, but so obviously that leads to a little more expense. But as far as their long-term survival, you know, longer term, like 2 years, 3 years out, from things relating to their colic surgery, it's the same. So we always kind of tell people, you know, for looking at doing surgery on your older horse, it is completely fine to, you know, to not want to do surgery, or, you know, not have, you know, for it not to be a good financial option for you. That's totally fine. But just because the horse is old isn't necessarily a reason not to do the surgery. And then another thing, just maybe unrelated, I always want to make sure owners know that when you bring your horse into a referral facility, a lot of people feel like they have to do the surgery, or they have to, you know, like they have to do all those things. That's not the case. Like, you know, our goal is to do what's in the best interest of your animal and your best interest as well, and to have a good outcome and a pain-free outcome. So you know, I know that my colleagues here and we always use just a team-based approach to make sure that we can accomplish that. And I would say most surgeons I know at any practice, you know, nobody wants to make you feel like you have to do surgery on your horse, or you know, or this sort of thing, or you have to spend this amount of money. That's not our goal at all. You know, we want to help you take care of your horse in a way that works out for everyone. So
the next question in the chat box is, how do you deal with the potential for post-surgical formations of adhesions?
That's a really good question. So intraoperatively, some things that we know increase our risk of adhesions are handling of the bowel. So we have some lubricants that we use in surgery. Carboxymethylcellulose hyaluronic acid is one of them. So we call it, you know, obviously belly jelly colloquially, but it's a special barrier protection sort of that we can put over, you know, we can use in surgery so that when we're handling the small intestine, it kind of makes it a little more slippery. The other thing is our actual handling of the small intestine. Like I'm very careful with it, and I make sure not to, you know, as a surgeon, obviously I'm a person that can be slightly obsessive. So I'd love to like recheck this and then check this again and that sort of thing. But if I've seen it and I'm really happy with it, then I just leave it be. We know surgical time is a big factor in that. So we try to be really efficient, you know, with all of our handling and with everything that we do in surgery. And then just not a lot of unnecessary motions or movements. So those are the big factors. Some horses, after a colic surgery, if they've had a resection or depending on what they had in their abdomen, will use a drain, an intra-abdominal drain. So we'll place that in surgery, and then we'll use that to lavage their abdomen after. So when they're standing, for 3 days post-operatively or 2 days, we will put fluid into their abdomen, and that sort of allows for a little bit of separation of, their small intestine or their large colon, and sort of floats those structures a little bit. I mean, obviously not a ton, but a little bit, and that can help. That can help as well. And again, we've done extensive studies on this. There aren't a lot of things that show up statistically besides surgical time to decrease our adhesion rate, but we do find that every surgeon kind of has their own style. I like to use the intestinal lubricants because there are no deleterious effects. There's no downside to using those, and so to me that makes me feel like I'm doing everything I can to limit adhesion formation.
Our next question in the chat box is, what can you do to prevent reoccurrence? First time colic 2 days ago.
Oh no. So this is a big thing. Owners always want to know what they did. What did you do wrong? You didn't do anything wrong. You're every horse that comes in that I have come in through here is very well taken care of, and we see the whole range from the horses, like my horses growing up that lived out on the back 40 to horses that live in completely perfectly padded stalls and everything like that. And everyone colics. It just happens to all horses. They're very poorly designed. So some of the things that we look at, if a horse comes in, if you have repeat colic episodes, one of your goals would be trying to figure out why they're colicking on those occasions. And obviously to use that, you're going to need to figure that out, you're going to need some diagnostics. So if you have a horse that has repeat mild colic episodes, then my recommendation would be to have your veterinarian out during one of those, even if normally they're just fine with a little bit of Banamine. It's all really, you can take care of it. It's all really self-limiting. Have your vet out to take a look, because repeat colics, we see everything from gastric ulcers, getting gastroscopy done. I really commonly do it on colic cases, just because it's a very easy rule out. It doesn't, it's very, very non-invasive. It's just a scope. It's not colic surgery or anything. So, and then it allows us we can treat a really painful problem for them. Not so much in this region. Other regions we can see enteroliths, which is actually a stone that forms in their GI tract, and that can cause just repeat low-grade colic, bladder stones, again, horses with ovarian problems, those sorts of issues. We can see repeat colic. So I'd say if your horse is showing repeat colic signs, have a vet out to take a look at them, and they can sort of help guide you to try to figure out why we think it is. Another thing about colic diagnostics in general, I'd say, the majority of colics are medically treated, even ones that come in hospital. And it's important, for people to know that sometimes not having an answer is a good thing. It seems like, oh, I got to know why they colic, but sometimes the only way I find out for sure is by doing colic surgery or a necropsy. So it's pretty good if your horse didn't have to have either of those things. So that's just kind of something to keep in mind, is that a lot of our, we're trying to figure out, there's this deep vault, and we're just trying to figure out why your horse is colicking. We might not, ambulatory vet, surgeon, internist, hospital clinician might not be able to figure out why, and that's not always a bad thing on the short term.
That was the last question in the chat box. Does anybody else have any questions that they would like to bring up? You can just unmute yourself and go ahead and chat, or put it in the chat box. I have a question. What are some things that you think a horse owner should have? I know you said a thermometer, but as far as medications or anything, if they were to put a little colic box together, what do you think that they should have on hand as a horse owner?
I think, for colic, really not much. I'd say knowing how to take your horse's vital signs, knowing, your resources. I'd say, you know, the biggest tool that you can have with your horses is a relationship with a veterinarian, like straight up. So, you know, someone that you trust, that, and whether or not it's them on call or that sort of thing, someone that you use for your vaccines, use the same vet every year, so that when, you know, even if they just see you twice a year, that's a big deal when they come out at like 2 a.m., you know, to look at your horse. They're going to know your horse a lot better. So having that vet's phone number available, have everybody know who to call. And then as far as, I think colic and, you know, the stethoscope and thermometer would be the big ones for me. And then, you know, basic bandage materials, you know, so the stuff that you would have for a laceration, basic emergency stuff, I think is, you know, still rings true. But I don't think that there's a lot of extra stuff for colic that you need to have. My biggest thing would just, you know, like the safety thing is very important to me, making sure that everyone stays safe.
Is one of them, oh, that's not a question. Oh, they were just saying they'd love to have more information on ulcers. Okay, that's actually a really good topic. Thank you. Is there any other questions out there for tonight? As always, you can email me. My email is on the email that you received for this webinar. So if there are no other questions, does walking the horse in the early stages do any good?
Yeah, I think walking, you know, we walk our colic horses, you know, our medical colics in hospital. So I think there's definite benefit to it. As long as it's not a really colicky horse, you know, as long as you're not walking them and they're trying to lay down and roll while you're walking them. Those ones I recommend just, you know, calling someone out, keeping them in the stall, that sort of thing. But definitely, you know, motility, walking around, that sort of thing that's really good for their GI tract. So yep, that's a good benefit. You know, the lunging, you know, 6 one, half dozen another on that. I think probably getting a horse all sweated up isn't great. I kind of think sometimes if we think about ourselves a little bit on those things, like I'm not going to go run a couple miles when I'm feeling, it's not going to make me feel better to run if I'm feeling bad, but you know, walking around, that sort of thing can improve your GI motility, definitely.
Do you think using wave PEMF therapy is good, or can it be contradictive when you first catch a horse colicking?
There haven't been, to my knowledge, any studies done on using that or on its effects on the gastrointestinal tract, so I really couldn't speak to that one way or another. I think the only downside of any therapy that you do would be, you know, we talked about the time factor already. So the big thing for, you know, as a horse owner is recognizing like, okay, this has kind of gone on long enough, you know, I need to get it in, because if surgery is an option, then I know that I want to get it into surgery quickly, because I'm going to have less complications, quicker recovery, all those things if I get them into surgery quickly. So, you know, I can't speak to that modality specifically, because there hasn't been any, you know, any controlled studies done on it in relation to colic, but I can, you know, anything that would delay you from referral or from veterinary evaluation, I'd probably recommend against, but if your horse is mildly colicky.
All right, well, thank you so much, Dr. Dern. Doctor, I just got a question of somebody who came on a little late. So this is Dr. Katie Dern. She's from Root and Riddle in Saratoga. And she focuses in surgery. She's an equine surgeon and came and talked about colic today. So thank you so much. I really appreciate it. I hope you guys will come back for our next 2 weeks. I forget which one's next. Nicolina, I know we have clicker training, and then we also have lameness. Is that right?
Next week is how to get your, it's about working horses with tendons and getting them back, easing them back into work.
All right, so that is our next week's topic, and I hope to see everyone there and maybe some more people. So thank you so much.
Thank you.
Have a great night, guys.